The reason we are doing this is because every day folks are dealing with new pain that doesn't go away.
Pain's a difficult thing to understand, so let people know what kind of options they have.
So Dr. Powers, so good to be back here in the studio that you prepared for the podcast. I'm sorry there's been a delay between podcasts, but we'll get back on a schedule now. You know, the holidays.
Yeah.
So this is number 7 podcast, which is named
Maximize Life Advances in Pain Treatment.
Thank you very much.
We're coming from pain specialists of Greater Chicago and Burr Ridge, Illinois, suburb of Chicago. And we have at the end of our podcast, just to remind everyone, a link to our website that you can go to make an appointment. We got a phone number there as well.
So again, I believe this is our 7th episode. We started out by giving a little background of ourselves and the practice, and then we jumped into some real exciting new stuff that we're doing in pain management that really gets our juices flowing because we're helping people we haven't been able to help before. Now we're going to take a step back, now that we hopefully have the audience enthralled with this information, and talk about the kind of treatments we do every day because they help probably 90% of our patients. We don't need these new specialized techniques for the majority of patients. And these are the simple treatments that have been around for a couple decades now, maybe 3 decades, where we're doing joint injections, we're doing nerve blocks, we're doing radiofrequency ablation of nerves coming out of joints, we're doing epidurals. Epidurals basically coming at the epidural space 3 different ways. These are the kind of things that a lot of people in the audience probably already had or are aware of, and we just want to talk, in a little more detail about them and what they actually do for patients and what their risks are and what the benefits are. Do you want to add on anything to the introduction?
Yeah. So, I think the simplest way to conceptualize, the spine for patients, I split it up into 3 different parts. I split it up when I talk to people about the spine, and I think today we're going to be talking about more the back of the spine. And we've already talked about the front of the spine. Front of the spine that's that intracept procedure that we talked about. Treats a lot of the pain that comes from the front of the spine.
The front of the spine being the vertebral bodies, the large vertebral bodies, and the specialized disc joint between them, right?
Yep, exactly.
That's in front of the spinal cord.
Yeah, so I divide it up into the front part, which is this large bone. That's the large bones that you think of when you're looking at the spine, the vertebral bodies. The middle part being where the spinal cord lives, where the spinal nerves are coming out of. And then I talk about the back of the spine. The back of the spine has joints. And I think you talked about at the beginning just how many joints in the back that there actually are.
Yes. I mean, it's like when a person comes to us with knee pain, it's one giant synovial joint, fluid-filled joint. With back pain, there's like all the facet joints and the disc joints, the whole, the square area would be the same as a knee. But unfortunately, there's not one way to treat all those joints at the same time, which makes it a little more challenging.
Yeah. So, I mean, you want to talk about people that have pain in the back of their spine, what type of symptoms they normally have?
Well, number 1, the facet joints are the most common cause of pain in the spine. That's just been proven scientifically. In the neck, it's like 90% of pain comes from the facet joints, 10% from the disc joint. If you have axial pain, that is pain centered around the spine. In the back, the disc joints are more commonly a cause of pain, but still the facet joints are the most common cause of pain. So when you see a doctor and you've developed chronic back pain and it's not going away, you're most likely going to, at least in our practice, we're going to treat your facets off the bat. The procedures we do are diagnostic and therapeutic. And because we know from the literature and our experience and board certification, we know the majority of pain is coming from the facet joints. So we treat those first because you can't really treat all of them at the same time for a variety of reasons, both diagnostically and the amount of steroid you can use in a setting. And so that's where we start typically, is doing a diagnostic and therapeutic facet joint injection. Go ahead. I can tell you're nodding your head. You have something to say.
Oh everything that you said, and these are people that have back pain when they're standing up, when they're leaning backwards. It could be pain when getting up from a seated position, first thing when you get up in the morning, being really stiff when you get out of bed. This is arthritis in your back, as you can have arthritis in your knee, and arthritis in the knee for not for everyone, but for some people can be painful. Arthritis in the back, while not for everyone, for some people can be painful.
Yes.
So it can be it can be anything from a sharp stabbing pain to a dull aching pain. It can be present all the time, or it can be present with certain movements.
This is true, and we're just talking about typically. I mean, typically people with facet joint pain, it hurts when they bend backwards. Typically, when they twist, it hurts their back pain. But, there are people with disc pain who have similar findings. What we really rely on is not for diagnosis. We don't rely on the physical exam or what the patient can or can't do. That might give us a hint. What we rely on is how they respond to the joint injections that we do. And it's diagnostic and therapeutic. And when we say that phrase, what that means is if you get relief immediately after a facet joint injection, that is the strongest scientific level of diagnosis that we're treating the correct cause of pain. That's a higher scientific standard than an MRI or a CAT scan or an X-ray. You can have an MRI that shows your facet joints look like hell and your disc joints look normal, and we could do a facet joint injection, and you might not get any pain relief. Well, that joint injection is more important diagnostically than what the MRI showed.
Yeah, because when people are coming in, they're coming in for pain. They're not coming in because they had a bad MRI. They've done studies on this, and about 89% of people by the time they hit the age 65 have MRI findings of facet joint arthritis on their MRI.
Correct.
Does not mean that person has any pain coming from their facet joint. So that's where these injections that we do become diagnostic, in the sense that we are targeting where the source of the pain is. We are figuring that out. We're answering a question, yes or no. And they can be therapeutic because they can reduce inflammation in that area, which can contribute to pain relief.
And to add on to your number, you're saying at age 65, I think you said 90% have facet joint arthritis. I have seen our radiologic articles at age 50, 99% of people have some form of degeneration. It might not be facet joint arthritis. It might just be disc desiccation, loss of fluid in the disc. So by age 50, everybody has evidence of some degeneration in their back. So you'll have an abnormal MRI. But at age 50, the estimates are between only about 12 to 18% of people are suffering back pain. So think about it. 99% of people have degenerative changes. 12 to 18%, some number like that, have pain. That's a lot of asymptomatic degenerative changes, and that's why you can't rely on the MRI for your diagnosis.
Yep. Abnormal MRI does not make you a broken person. It doesn't mean that there's something wrong. If you have symptoms from that, it can help us figure out where is the best place to start to look for where your pain is. So that's how we use the MRI.
And that's an excellent point, because the procedures we do are to treat symptoms. We tell patients all the time, you're doing great. We did a facet joint injection. You have no pain now. Your pain's minimal. It's tolerable. But we tell them your MRI looks exactly the same now as it did before we did that facet joint injection. Mm-hmm. So it's kind of a warning for folks to be careful, mm-hmm. to do the things that they learned in physical therapy, to maintain the health of their back with the stretching and strengthening, and avoiding high-risk activity. And some folks can do that, and other folks want to get back to what they were doing before, skiing or something aggressive like that. And sometimes they get away with it, and sometimes they come back for another injection after they exacerbate their back pain.
Yeah. So the things that we do, the things that we treat, are helping people live, a relatively normal life. Yeah, there are modifications that maybe they learned in physical therapy about how they can still live that normal life, but do it in a safe way, definitely. But patients are coming in to see us because they have pain, not because of the abnormal MRI.
Exactly.
Yeah.
Exactly. And the biggest reason, another little pearl for the audience, the biggest reason we get MRIs are not for diagnostic reasons per se, but to make sure there's nothing crazy causing the pain. That's the biggest thing. We don't want, it's happened once or twice to me. I can remember pretty well. I remember really well, where we discovered cancer was the cause of the pain, metastatic cancer. Patient, we had no idea until we got the MRI. Other things that can cause pain that you wouldn't, you wouldn't expect would be, say somebody had some trauma, they might have a fracture. So that's not facet joint pain. That's the fracture causing the pain possibly. Or infection. That's thank God that's never been the something that I discovered. I was the first person to discover, but that's how we get the MRI, to make sure there's nothing we would never foresee as being the cause of the pain. Because whatever it shows probably isn't going to change our diagnostic treatment. And again, we're talking about axial pain. If a patient has pain going down their leg, we're talking about the lumbar spine now, down their leg, that is sciatica, that's the common term. That's nerve inflammation, because the spine protects all the nerves coming off the spinal cord. So if you have an injured facet joint or disc joint or both, that inflammation can either chemically affect that nerve or even physically, if it's a bad enough herniated disc where it's actually touching the nerve. And so if you have pain in your leg, an MRI might give us information about which disc is causing your pain. But even then, it's more important if they have the physical exam in that case can be important, because if the pain goes into their big toe, say, we know that's the L4 nerve based on the dermatome. So that's even more important than the MRI. Yeah. But again, the MRI might help us a little more with people who have radicular pain. Agreed?
Agreed. Thanks everyone for joining us to talk about facet joint mediated pain or back of the spine pain.
Well, everybody understands now that the facet joint is the most common cause of pain. The next episode, all about facet joint treatment. How about that?
There we go. All right.
Thank
you
so
everyone
much.
Then. Thanks.